The Next Breast Thing podcast is primarily funded by the American Society of Breast Surgeons. The support of sponsorships helps us offset some production costs. ASBRS does not endorse or co-promote any company, product, or service mentioned.
This episode of The Next Breast Thing is made possible in part through the generous support of Myriad Oncology, Solventa Prevena Therapy, and Mamatome.
Myriad Oncology provides a portfolio of advanced genetic and tumor genomic testing solutions, including risk assessment, screening, tools to aid treatment guidance, and survivorship planning. The Myriad Oncology offering is designed to meet the unique needs of oncology specialists and their patients across each step in the patient care continuum.
To learn more, visit myriad.com/oncology.
Solventum Prevena Therapy has demonstrated a significant reduction in surgical site complications, infections, and readmissions. Take a proactive risk management approach. With Prevena Therapy, learn more at prevena.com. That's prevena.com.
At Mamatome, we offer a comprehensive range of products that deliver better outcomes in breast care. From biopsy to surgery, our advanced technologies empower clinicians with precise, trusted solutions. Together, we will transform the future of breast care. Learn more at mamatome.com.
Hey listeners, want us to let you know when new episodes are available? Simply hit the subscribe or follow button on the Next Breast Thing podcast, wherever you listen to podcasts.
On this episode of The Next Breast Thing,
How to best navigate genetic testing with our patients.
We didn't really do a good job at looking to see whether someone needed to be tested or not. And so half the time we missed.
In the age of 23andMe, you're not going to stop people from doing genetic testing, and surgeons are...
Now the whole paradigm has shifted where...
Everyone does this differently. So Ellie, how do you do this in your office?
In my clinic, I don't get to make any of these decisions. This is all...
How do you decide which company to use?
Have any of you ever started the genetics program from scratch? Or...
Do you always get the same test, or does it vary based on...
We're having to go back and retest people that only had BRCA1 and 2 testing previously.
I just got slammed at breast conference. Like, what is wrong with you? You tested this 95-year-old. She doesn't really have a family history. What is wrong with you?
this is Carla,
Ellie,
Michael,
Susie,
and Susan. Welcome to The Next Breast Thing, a podcast by the American Society of Breast Surgeons for the entire breast community.
We're a group of devoted surgeons from different parts of the country,
inviting you to journey with us into the science of breast
through the heart and soul of our breast community.
From advances in procedures and patient care to personal transformation, we're here to support you.
So, if you're part of the breast community and can't seem to find the answers, this is the next breast thing.
Genetic testing now sits at the crossroads of screening, surgical planning, and survivorship. But our approaches and workflow can vary. For example, who's testing in office? Who sends to genetic counselors? Who refers and when? And how do we talk to patients about genetic testing?
In this episode, we're talking about how to best navigate genetic testing with our patients. And fortunately, we're not alone. With us today is Dr. Eric Manahan, a board-certified general surgeon who has served the Dalton, Georgia community for nearly 25 years.
Eric serves as the co-director of the breast program at People's Cancer Institute and maintains a robust general surgery practice in a community hospital setting. He has chaired the Department of Surgery at Hamilton Medical Center and has served as the chair of the hospital's cancer committee. Eric is nationally recognized for his leadership in breast surgery, in addition to his current role as the president-elect of the ASBRS. Eric has also chaired a national panel of experts to develop the ASBRS consensus statement on genetic testing for breast cancer. Eric, welcome to the Next Breast Thing podcast.
I'm happy to be here. I've been sitting at home every week, just sitting by the phone waiting for you to call. Thanks for finally giving me a shot.
Before we dive into today's topic, Eric, we'd love for you to share your story with our listeners.
Grew up in Tennessee, then went off to Auburn for undergraduate. I'm a big Auburn Tiger. I then came back home to go to medical school and did a general surgery residency in Johnson City, Tennessee, and then joined a surgical group here in Dalton, Georgia, the carpet capital of the world, where we had a group of about 4 or 5 of us that trained together, all from the same institution doing general surgery. I was the youngest junior partner for life as I joined the group. Then once I got into private practice in the general surgery world, I kind of defaulted into doing a lot of breast surgery and realized that we needed to do a better job. And so that's how I started looking into the American Society of Breast Surgery as a way to figure out how to do ultrasound biopsies. Michael and Ricky, I went to one of their courses and realized that that was a good place to learn how to do ultrasound. We bought a biopsy machine, trying to do the best we could in treating the local community with what someone should really receive anywhere they go. From there, I kept volunteering for a lot of things, and eventually I got put on an education committee at the American Society of Breast Surgery, and from there was able to do some site visits where I was able to travel around all these big programs, big academic centers, and figure out what they're doing. So I met a lot of people in the society, and I got asked to start doing more things, and just the more things I said yes to, the more things they asked to do, and eventually got onto some other committees and then the board, and here I am. In 2018, when I was a young board member, the genetic testing controversies were coming out as to the guidelines and where do we stand and what should we do, and there's a lot of controversy. I got asked to help lead a group to figure out what the American Society should be as far as a genetic testing, where we really thought we should stand. And from that point, we dove into the data and reached out across the United States, academic, private, medical oncology, big names in genetics, big names in different societies, really just trying to figure out where we should be in that space. A study came out, a pretty well quoted study from Peter Beich and their group, where they looked at some in vitro data, and the national guidelines with NCCN, which most people were following at that time, where it was about a 50-50 shot as to whether or not you really got what you needed out of them and whether or not a patient had a variant or not. And so we really found out that we didn't really do a good job at looking to see whether someone needed to be tested or not. And so half the time we missed whether they had a pathogenic variant or not. And as we dove into the data, we really decided to not necessarily test everybody that's diagnosed with breast cancer, but really think about testing every patient diagnosed with breast cancer at the time. Now, we know everybody can pull out the 98-year-old with no relatives and no need to test, but we can think about that person still. I mean, what if they have a family history that goes on a little further? Are we missing people? Is that 90-year-old, is that a triple negative that really has some family members that we can catch up with cascade testing, and they were lucky to not get a cancer?
Eric, what did it look like before 2019? Say you have a patient coming in with breast cancer, before you guys put out the guidelines, who was getting tested? What was happening?
So in 2018, the NCCN guidelines were really pretty complex. You had to go through a pretty significant algorithm to figure out how many relatives had cancer, what age they were, what types of cancer, did they have ovarian cancer, breast cancer. You had to really go through a strange algorithm. And we always said it's kind of like if your aunt was a left-handed softball pitcher, then maybe they deserved genetic testing, but it was too hard to figure out. I mean, you'd spend 20 minutes in the office just going down the algorithm trying to figure out if they need it or not. And so then you ended up just not testing anyone. So it just was too hard to figure out.
I was on that NCCN panel, and we would see that in action. And there'd be instances where if you were less than 40, you would test. If you were greater than 45, with certain circumstances, you'd test. But if you were between 40 and 45, you wouldn't. It just was very difficult. And they wanted to be very data-based, and maybe there wasn't a study on a 40 to 45-year-old. And it became almost this Rube Goldberg thing of trying to figure out who was and who wasn't. What I did find in that is they really were spending a lot of time trying to protect the genetic counselors. And it was to really only test those people that the number of genetic counselors could handle. So they were trying to protect them from a big influx of patients. And then they were very interested on things that were, quote, actionable. Now, you could have different definitions of actionable. Is it a drug that we can give that patient? Well, to me, actionable could be if there are family members that could be tested and affected. So they weren't really spending as much time on that. So it was very interesting. While I was serving, these guidelines came out, and I presented that to the NCCN panel. I said, in the age of 23andMe, you're not going to stop people from doing genetic testing, and surgeons are going to test. So you better figure out a backstop that is going to be acceptable to you. And, that was my last year on that panel for one reason or the other. Maybe I created too much of a stir, but that's what I kept seeing. Was it actionable? How do we get all of these patients in to see the genetic counselor? And our point is they don't need to see a genetic counselor for all of these negative tests that we're doing.
Time has proven us right. From 2019 till now, we were worlds apart by saying everybody with breast cancer should be considered for testing. That was crazy talk back then.
Yeah.
So compared to where they were in 2019, now the whole paradigm has shifted where we're very close together. The guidelines right now, there's a small gap. Once Olympia came out and the triple negatives came out, all triple negatives are getting tested. The PARP inhibitors really made the window so small. So we're pretty close, but it's still complicated. I still wonder sometimes it can be very difficult looking at the NCCN or the SSO/ASCO guidelines, which have great people on it that came up super smart. But I'm not that smart to be able to figure it out. And so I need to be able to know that one person in front of me's got breast cancer. Maybe it's population testing, but it's in a defined cohort where we're not going to miss people, and we're going to hit the cascade testing if we need to so that we can capture people, because we're still doing very poorly across the United States and across the world in figuring out all of the genetic pathogenic variants that are out there.
I don't think of these other guidelines as complex. I think of them as just limiting. And I think our goal at ASBRS was to not miss anyone, because missing someone with a genetic mutation can be life-altering for them and their entire family. I look at us as we were more inclusive and did not want to miss anything, and all of these other organizations were just limiting in that they were accepting missing half of genetic mutations. And I commend our society for really taking the lead in this. I remember, because I was on the panel with you, or the task force, whatever it was, I was most shocked with National Society for Genetic Counselors in that they did not want to join us. They didn't agree with us. Can you recall your reaction at the time to their saying, "We disagree with you"?
We had a lot of discussions about that because we thought this was an easy ask to help pull them in. As Michael was saying, trying to figure out, how do you get the pre-test counseling done? Who do you test? The limiting factor of the number of genetic counselors, and whether surgeons should be able to test people for genetic counseling. A lot of people didn't think they could, but we did get to agree that we're surgeons and we're seeing these patients. And as long as we understand and have educated ourselves through either this venue or some other venue to be able to learn how to understand genetic testing, we need the genetic counselors. They're great at doing what they do, and we want them for the hard things. I don't think, personally, we need a genetic counselor to do the pre-test counseling for a patient with breast cancer. I can see so many of those patients that are going to end up 95% plus are going to end up being negative. I want them to really spend the time with the positives and help me with the cascade testing and help me figure out what I need to do with this moderate penetrance gene. Genetic testing can be scary in the world of genetics. It's a practice unto itself, and the genetic counselors are so valuable, but we need them for the really complex variants to really figure out how to best manage them. If you ask most of them, that's what they want to do too, rather than just take family histories and pedigrees, which we can do in the office pretty quickly.
I agree with you, and everyone does this differently. So, Ellie, how do you do this in your office? You see a new cancer patient. What's the process in the office?
I see a new cancer patient. I am generally the one that's identifying them for genetic testing. I speak to them about it, make a referral to a genetic counselor. At that time, I talk to the patient and say, we're looking for these certain genes that do have a benefit to do more surgery. I kind of tie it into the mastectomy discussion when I talk about BRCA1 and BRCA2 and a survival benefit to that. So I'm definitely talking about genetics at that first consult. And then I make the referral to the genetic counselor. They do see them for a consult and perform the testing. The way it's set up in my clinic, we get a rapid test back in about a week that tests for BRCA1 or BRCA2, and that's super helpful. That's usually before the surgery has happened. So I'm able to take that information, if it is positive, to the patient and together make joint decision making. And then we go from there. And then the full panel of 80 genes comes back then. If they've had previous testing before 2013, we get them updated. But I do have genetic counselors at my fingertips, so I do use them. A lot of places don't have them. A lot of doctors are doing the genetic testing themselves and the counseling and all of that. So that's been my experience. Have any of you ever started the genetics program from scratch? Do you do it yourself first? Do you hire a genetic counselor? How does that roll out?
So when I first joined the practice that I'm in, they had 5 genetic counselors on staff, and it was really easy to use the genetic counselor. And they kept getting hired away by the genetics companies to where we got down to 1. So just by the sheer numbers of folks, this wasn't going to be feasible to send all these folks to the genetic counselor. Now, what's really been nice is a lot of these genetic companies will set up a service that is fairly turnkey, as a matter of fact. So I will talk to the patients that are newly diagnosed, and I'll discuss with them the benefits of genetic testing. And I will leave them on a video call with a counselor that is on call 24/7, basically. And they'll run through that. They'll get the basic information. When they're done, I'll come back in, ask them if they want to test. If they do, I'll go ahead and send a sample at that time. Most of these are going to be negative and nothing that we're going to do anything with. And if they are, great, I'll call them and tell them that that's what it showed. And if it's not, if it's a VUS, I'll talk to them about the fact that we just consider that a negative. But if there's somebody that's really highly suspicious and we still are concerned about something going on, even though their test is negative, we'll get them into the genetic counselor. If they're positive, we'll get them into the genetic counselor. But it really streamlines the process. And it's really interesting. Sometimes they're less concerned about themselves and more concerned about their family members. Mm-hmm. That seems to be an impetus for a lot of patients of, I'm not going to do anything different, but if I have a mutation, I would want my kids to know. And so that's a lot of the impetus there. But it makes it easy when you can have a turnkey situation like that. Patients aren't going from place to place and waiting for the big reveal. It's just part of the cancer talk discussion and the initial consultation.
I have to say, at my hospital, we are enormously lucky that we have 3 genetic counselors, but yet we do all point of care cancer testing, because that is a little more complicated to figure out. We know that we're going to offer testing to all cancer patients, so we just do it then and there. I really do not like taking a patient to the operating room without their genetic testing result, because it may change what they do. So I like to have that back. I don't want to waste time. So it's just as easy in the office to get it. My question is this: how do you decide which company to use, which test to get? Is there a difference?
Here's how I decide. I look over at my medical assistant and see which box she's holding, because it's probably the company that made her the least mad. Now we bounce around from 1 to 2 to 3 and bounce back and forth. And we're pretty loyal, but I can tell when somebody has not gotten us a test back or we haven't got the customer service that we need. And they're pretty close. The big reputable companies, I think some reports are better, but a lot of it comes down to customer service. And I can tell when she's mad at a company, and she knows about as much about genetics as I do because she's super smart. And so we test everybody. And what Michael said too, the variant of uncertain significance, when we're ever talking about this genetic testing guideline, is not actionable. So make sure we throw that in, and then I'll go back to letting the others say how they decide.
Do you always get the same test, or does it vary based on the family history?
I'm getting the multi-gene panel pretty much every time. I'm getting a big panel, and we'll figure it out on the back end. I know sometimes that maybe we wish we hadn't, but I think in the end, a lot of times when I have this discussion and do the pre-test counseling with all the affected patients. Now, the unaffected patients we send through and pretty much go along with the NCCN guidelines. But when I have an affected patient in front of me, I like to just test them all, and we don't have to go back and retest people with different genes. And so I like to get a big multi-gene panel.
In my clinic, I don't get to make any of these decisions. This is all decided with the genetic counselor and the patient. They give them a counseling on like the rapid test versus the 80 gene panel that we have available. And there's only one that they have a contract with. And so I'm out of that conversation, and I wonder if I should be in it. Like I said, I'm spoiled, and this has all been done for me, and I didn't really realize that there's a difference.
So Ellie, I don't know if it's referred to as being spoiled, because as the breast surgical oncologist, it is still our responsibility. Even if I'm not testing, they certainly do not want me taking blood from them as their surgeon, but it is my job to know about it, to be involved in the process of it. Just like we have to know the different types of chemotherapy. We're not giving chemotherapy. I don't know the dosing per se, but I have to know the names and why we're giving one and not the other, when we use adriamycin, when we don't. I think genetic testing is the same thing. We have to understand this. Michael, what's your thoughts on it?
Well, I mean, it depends on who you talk to, right? Some companies will say, look, we've got the most data, therefore we can be the most accurate. And what one company is calling a VUS, we define as pathogenic, or vice versa. I like more information. More information's better. I'm old enough to know that we're having to go back and retest people that only had BRCA1 and 2 testing previously. Now that
even before BART existed.
Exactly. So give me more. I also realize that we're probably only looking for about 5 gene mutations that affect breast. So what do we do with all these other stuff that have colon cancer risks or other things? I think it's important to have that information. If you're going to send a sample and you have the ability to get this information, then get it. And some companies have the ability to parse out things like CHEK2 mutations that when you start looking at, well, what's the risk range? Well, it's 10 to 80%. What? But they're able to parse that out into high risk, intermediate risk, or low risk CHEK2 mutations. Each company has a little bit to offer that others don't. Sometimes it comes down to cost, and that's been more of a thing historically than it is currently. We would have patients that we would generally like to use one company, but their insurance wouldn't cover that, or that it was going to be completely out of pocket, and another company would provide it at a steep discount. So that comes in, but I would say that 90% of our tests stay with one company.
But Michael, just for our listeners out there, cost is not really an issue anymore.
That's why I said historically, that was a thing, but the playing field's been pretty leveled right now.
But I do have patients, Medicare, especially, you're talking about somebody who's over the Medicare age, but they are interested in their children and knowing their risk. And yeah, I've tried to order genetic testing for them, and they say, oh, Medicare won't pay for this. It's going to be $500. Do you want me to get it?
Well, it's $250 from just about every company if you are paying cash. And they've really all leveled the playing fields on that. Now, $250 is super affordable for some people, but for the average American, $250 is not affordable for a crisis in their life. They don't have those emergency funds, but it is about $250 across the board. With that being the level playing field, do you look at VUSs? Do you look at the VUS rate overall? Do you look at the VUS rate that a company has for BRCA 1 and 2? Do you look at the overall panel? Are these important issues when deciding which test?
I will tell you, I have learned more, and some of my choices have come down to the education provided by the genetic companies themselves. So I'll have a genetic counselor that's my rep that has taught me more about genetic counseling that I could ever think about. Having said that, the more they've taught me, the more I start questioning, and then one company will tell you one thing and one company will tell you another thing. So finally, I just decided that I'm going to go do the City of Hope genetics course. And so I'm in the middle of that right now. So it's a very awesome course that the City of Hope puts on online, but it's a lot of work. Reminds me of getting an MBA. And so it's a lot of online work and things to listen to and tests. But it's been phenomenal just kind of deep diving the genetics world. It's been super helpful for me to help figure out a lot of these other things. And when you pull up a Lynch syndrome or something, what do I do with that? And what's that even mean? And some people said early on they were afraid to order the genetic testing because what happens if it's a gene I don't know anything about? It's like, well, what happens when you get a CT scan of an abdomen and it shows something in a kidney? You don't mess with that. You send it to somebody that does. So there's people out there that are going to help you.
So what happens when you get a mutation for Lynch syndrome back? Are you responsible for referring that patient out? What do you do with the BRCA2 mutation?
That's where I heavily rely on our genetic counselor colleagues and even the genetic counselors in the companies themselves that can help steer that patient the correct way, give them more information and deep dive with that patient, and more importantly, help us to figure out cascade testing. So if you're positive, then you have a 50-50 that a son or daughter has the mutation, or a sister, brother. So just going out through the relatives. That's what we really want to find. You want to find that positive test so you can hit all their family members. To quote Susan Boble, we failed our job when we see an affected cancer patient in our office and they're positive for genetic testing. That's a fail.
The system failed them.
We need to find that patient with the genetic mutation before anything has ever happened so that then we can help them to decide what they may want to do for primary prevention or other risk reduction strategies. So it's a fail when we're in our office and we test somebody positively.
So my famous story, and you might have heard this before, was years ago, I had the cutest 95-year-old patient diagnosed with breast cancer, and I offered to test her. And for some reason, I presented the case at breast conference, and I just got slammed at breast conference. What is wrong with you? You tested this 95-year-old. She doesn't really have a family history. What is wrong with you? She comes back positive. Shocking. She comes back positive. She has 5 children. They all test. 3 come back positive. Her grandchildren then get tested. One of the granddaughters who had a gene mutation decided to have a BSO, and she had fallopian tube cancer. And we potentially saved her life. And that is why we test people. And I tell patients as they're older, this is not going to change anything we do for you at all, but it's incredibly important information for your family. That's defined as success when we found that patient and then potentially altered the path of everyone else in her family's lives. That's success.
100%. One of the very first patients after we started testing everyone in my practice, I sent off the test and they ended up having a mutation. We already had the test back, but my slide that I show is the insurance company denial of the test that ended up being positive. And once again, she had a fallopian tube cancer that was found. Then we cascade tested the family. But I like to put up the slide that showed that the test was positive, the insurance company denied it, and they didn't meet, quote, guidelines. we got lucky is what essentially that one was, but it was a success. Otherwise, it's a failure.
But ASBRS was so ahead of the curve with this one and really visionary and altered outcome and altered patients' lives and families' lives because of this. Before we wrap up, Ellie, tell me one thing you learned. Tell me how you were enlightened by this podcast tonight.
Well, I learned that if someone comes into the office and has a BRCA mutation with a cancer, it's a failure. I haven't thought of it that way, but it's true. It's a powerful point. So we've got to do better. We've got to use our technology and do better for our patients. So thank you.
Michael?
You don't have to be in a big system to do genetic testing. The tools are out there that make it very accessible for you to add this to your practice. You can do this. You should do this. This should be part of every breast surgeon's practice, that they are doing genetic testing, that we need to identify these patients. It's going to affect their outcome. It's going to affect their family's outcome. There's really not an excuse for not including this in your practice.
I think that is such an incredibly important point that you have made. And Eric, honestly, as the lead author on this paper, this really was practice changing. This was a paradigm shift. So I am grateful for your expertise with this. But I just can't believe we're out of time again. Eric, we could go on and on about this topic. I think it's a topic that's near and dear to our hearts here and know what a difference it makes. It's been a pleasure having you on with us. We finally made the phone call to have you as a guest. So thanks so much for joining us on this episode of The Next Breast Thing.
Thanks. As much fun as it is to sit back and listen to y'all talk and listen to the podcast and hear about Bovie the cow, it's even more fun to be on it. So I appreciate the chance to get to come on here. And I'm sorry I didn't use my radio voice like Michael Berry, but
Absolutely.
It's a great time.
And, you know, if you still behave well during your presidency, maybe we'll have you back on. To our listeners throughout the entire breast community, we're so excited once again that you've joined us on this journey, and we'll see you next time on the Next Breast Thing podcast.
We look forward to connecting with you on the next episode of The Next Breast Thing, a podcast by the American Society of Breast Surgeons for the breast community.
Also, join the conversation on our Facebook group by searching the Next Breast Thing podcast group on Facebook.
Finally, the content within the Next Breast Thing podcast represents the views, thoughts, and opinions of the co-host and may not necessarily reflect the views, thoughts, and opinions of the American Society of Breast Surgeons.
Until next time, this is Carla,
Ellie,
Michael,
Susie,
and Susan. And always remember, if you're part of the breast community and can't seem to find the answers, this is the Next Breast Thing.